Call the Fiscal Committee meeting to order. Lousy drive today. I don't know about anyone else that was out there on 93 or 89, but it was not fun. So, anyhow, but this will be lots of fun. So I'm really, really glad that I made it here safely. So, the first item on the agenda is acceptance of minutes of the September 6th and September 9th meetings. Could I have a motion, please?
So moved.
Thank you.
Second.
Motion made by Senator Bradley, seconded by Senator, my mind went blank, Daniels. All those in favor, please raise your hand. Oh, okay. All right. Motion passes. Okay. Is there anyone that desires to take FIS? Oh, I thought I did both at the same time.
Oh, both at the same time?
Yeah.
Sorry.
That's quite all right. it's early. Let's see. Is there anyone who desires to take FIS 22-23 off the table? Seeing none. Okay. The items that will be taken off the consent calendar are under tab 5, FIS 339. Under tab 7, FIS 222326. FIS.
Did you say the last three numbers again? I'm sorry.
Mm-hmm. 326. FIS 22351. FIS 359. FIS 22361. FIS 22362. FIS 22363. The Department of Health and Human Services and the Department of Administrative Services have requested that FIS 22365 be taken off the calendar and withdrawn. FIS 22366. And I believe that is it. So could I have a motion to accept the remaining items? Thank you. Senator Bradley moves and Senator Rosenwald seconds. Your mic is not on.
Clarification. So on tab 12, we haven't talked about whether or not the ones that deep into the agenda are pulled. They're not on consent? All right.
They're not on consent.
Good. Thank you.
Are you? Okay. All those in favor, please raise your hand. Senator Rosenwald? Senator Susie? Okay, thank you. The vote is unanimous. Thank you all for coming. I can't believe you're leaving. This is so much fun. What a day. We'll wait. FIS 22 326, Department of Health and Human Services, authorization to reallocate federal funds in the amount of $550,000. 326, tab 7.
Good morning, Nathan White.
Oh, I'm sorry. I did. Excuse me. I'll go back. It's still Health and Human Services. It's FIS 22339, which is to accept and expend $1.35567 in federal funds. So, Representative Erf, I believe that you had questions on this.
Yeah, thank you, Madam Chair. There you are. So, as I understand it, this grant is to administer an ongoing demonstration program. Can you provide an overview of what new is being demonstrated and how the development will play out through the September 2026 timeframe, and when the program can be expected to impact the general fund in the budget cycle?
Sure. I'm Chris Santinello, Associate Commissioner. So for the first 16 months, so we just were awarded the funds the end of August. So for the first 16 months, we're really working on to develop an operational protocol so that we can determine what we want to do for services after the first 16 months. What do we want to enhance? And so any people that we transition from institutions would not really impact the general funds until after this grant award, because we get an enhanced match for those folks through Medicaid. That's later on in the proposal.
When you say through the grant award goes through 2026, correct?
Correct. Yes.
So there'll be no impact till after that?
Until after that, correct.
Okay. And what new might be demonstrated?
So one of the things we're really looking at in the first year is to really understand the home and community-based service system so that we can enhance that, right, for the seniors that we serve in the state. So we really want to do some gap analysis as to where there are pockets within the state that maybe we need to enhance home and community-based services so more people access that. We want to look at some quality measures. We also want to really understand and study what is needed for nursing facility beds within the state. So it's really a lot of research and understanding the current service delivery system. You're welcome.
Senator Rosenwald?
Thank you, Madam Chair. So we've been running this program since 2007,
So
5.
we had excuse me. We had it originally in 2007, and our program ended in 2019, and then additional federal funds were made available to states, and so New Hampshire qualified. And really, what we want to look at this round, and in the previous round, we really looked at, okay, transitioning people from institutions into the community. And really our focus this time around is how do we divert people and keep them in the community for as long as possible.
Thank you. So over the 12 years we ran the program, we transitioned a total of 41
Correct.
individuals, or between 3 and 4 per year.
Correct.
Are we expecting that this new iteration will be cost neutral? I mean, because we've spent a lot of money on 3 or 4 people a year.
Yeah, it definitely, because we're really looking at how do we strengthen our home and community-based service system so people don't end up in nursing facilities.
And final question.
Sure.
Do we actually have the workforce that we need to be able to keep people in the CFI program?
So workforce is always a challenge, and really what we're hoping to do is through our assessments and developing the operational protocol, we'll really understand that better.
Thank you.
You're welcome.
Are there any further questions?
Thank you,
Representative
Madam
Edwards.
Chair. So, so this has very much a system of care feel to it. And whenever we talk about system of care and the obvious desirability of building up community-based care supports, I'm always left with the question, are these community-based supports going to be sustainable? We've been pumping a lot of federal money into these programs, and so I just want us to start to get our head around the future when it's New Hampshire taxpayers again and these programs. And so it's a very general sort of comment or concern. Do you want to talk to that?
I mean, I think what we really want to try to do is understand how do we strengthen those systems, because we're spending the money for this population regardless, whether it's in a nursing facility, whether it's in the home in their own community. And we know the longer people can remain at home, it does bring down the cost of institutional care. And so how do we shift in that direction, and really develop what we need to do to keep people for as long as they want to be and are able to be safely at home.
Follow up?
All right. So this is what I think I want to hear you just said. I want to hear that you just said that we are going to change the optimization of the services so that we reduce our overall cost mix, and hopefully at the end of the programs, we will be left with a financially sustainable model.
We want to work towards that and work together in partnership with all of our partners to make sure that happens, that people can remain at home for as long as they can.
Senator Daniels.
Thank you. I'd like to follow up on some questions from the senator from Nashua. If this program started in 2007, and I think you talked about 2019, why did we not do any monitoring, in that 12 years to determine what changes needed to be made to a system if you're only helping 4 people a year?
We did do some monitoring. The system last time was really broad-based across all of the disability communities. And this is really focused on our elderly and adult service system, because we know with the aging number of people aging in the state that we really want to focus on this opportunity. And there's been more flexibilities actually with this next round of funding that actually includes people a shorter period of time to be institutionalized. And so hospital transfers and all of those pieces will be super important.
So to expect the population that you're going to be dealing with is the same population as before, or is it going to be expanded? And where do you expect that the help is going to be given?
Sure. This focus of this round is really on our elderly and adult service system. So those individuals who are eligible for the Choices for Independence waiver, but really focused on our older seniors in the state.
Thank you.
Are there further questions? Could I have a motion to accept? Thank you, Senator Bradley. Second by Senator Gray. Will the clerk please call the roll?
This is on 339. Representative Edwards.
On 339, yes.
Emmerich votes yes. Representative Erf.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley. Yes. Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susie. Yes. Representative Umberger.
Yes.
Madam Chair, the vote is 10 yea.
Motion passes 10-0. We now move to the one I was messed up on, FIS 22326, which is in tab 7. Representative Erf, did you have questions?
I did. Thank you, Madam Chair. Here we go. So and I've really tried hard at this. I'm trying to understand where these federal funds are coming from and what they were for. The explanation indicates that SABG funds cannot be used to address alcohol and related misuse. It also states a governor's commission made a presumably previous appropriation to address this. A response to a question trying to clarify where the funds are coming from referred to two fiscal notes from last year, FIS 21-232 and 21-251, both of which, as I read them, are SABG and thus presumably not allowed for alcohol abuse. So I have two questions. The first is a compound question. What is the source of the funds being transferred in this note? And what were these funds being transferred originally intended to do beyond, quote, two IT-related infrastructure projects? And the second question I have relates to the note itself. Are the payments actually to clients or to their service providers?
All right. I didn't take notes, but I will try to address all of those questions with Nathan's help. So for the record, I'm Katya Fox. I'm the director of the Division for Behavioral Health. And for this particular item, there's substance abuse block grant, which we receive from the federal government on an annual basis, is a certain amount. We received a supplemental block grant as a result of federal action to add funds to address the pandemic. And so they are restricted, but the funds that are restricted for, it's a little confusing. So we always get this block grant dollars. They have restrictions. We, in addition to the block grant dollars, we also receive state opioid response funds. Those are the ones that are restricted from using to address the needs of individuals who have perhaps an alcohol use disorder versus an opioid use disorder. And so the reference there, it's a little confusing. We probably didn't do a good job in that explanation. SOR funds are not at play. We're talking about the block grant funds in this particular action. With the reference to the fiscal item, that was something that you accepted with the supplemental. And the other funds, so that's the 250 that's referenced here, and I'll explain what we had intended to use those funds for. And then the 300,000, that is from the budget. So those were block grant funds that were in the budget. Do you want me to go on?
Okay, so 300,000 was in the budget. You're going to explain to me where in the budget. And the other was where?
So it was accepted. That's the reference to the dollars that were accepted last year by Fiscal Committee.
Which note?
Go ahead.
Sure. So on page 1 of the item that you have in front of you, you'll see account the last string of numbers there, 1981. The $250,000, that's what was previously accepted via the Fiscal Committee outside of the operating budget.
But can you tell me what fiscal note?
Oh, what fiscal item?
Yes.
Yes. So that was fiscal item approved on September 17th, 2021, FIS 21-232.
Okay, hang on. Yep. So I got that.
Yep.
And maybe I'm just misinterpreting what is written here, but I thought it wrote here in this particular note that SABG funds can't be used to address alcohol and related misuse. Did I misinterpret that?
I don't have that right in front of me, but that's not the case. So SABG funds can be used to address all substances that someone may be have an addiction to.
Okay.
So the reference was that because of the one-time funds we received from the Governor's Commission were used to address the needs of individuals at the doorways for non-opioid related issues. We are picking up where the Governor's Commission funds left off and using these funds which have been identified. And I'll get to that part of your question if you'd like me to.
Yes,
So
thank you.
the 250 had been set aside. And when we develop these proposals, we have a short amount of time. We have brainstorming sessions within the department to address what gaps are there. And so the original intent of that 250 was to invest in what is known as prescription digital therapeutics. And that boils down to it is an adjunct to treatment services, and it's really an app. And it provides at the individual level a physician the ability to see how a patient is doing. And so that project never got off the ground. So that probably would have required a RFP, a request for proposals, and gone through that process. So those funds didn't move forward for that purpose, and we're asking that they be repurposed for the doorway unmet needs.
Thank you.
Are there further questions? Seeing none, could I have a motion?
Move the item.
Representative Erf, seconded by Senator Bradley. Will the clerk please call the roll?
Roll call on 326. Representative Edwards.
Yes on 326.
Henrik votes yes. Representative Erf.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley. Yes. Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susie. Yes. Representative Umberger.
Yes.
Madam Chair, the vote is 10-0.
The vote being 10-0, FIS 22326 is approved. We now turn to FIS 22351. I do not need safety up yet. What I need is Commissioner Caswell or whomever to come up and talk to us about this new program called SWEEP. Since this came to fiscal and there had not been any previous discussion about what the object of this program was, some of the committee wanted to know what we were trying to do.
Sure.
So if
Certainly.
you could.
Thank you, Madam Chair, for the opportunity. So SWEEP, and admittedly we're running out of acronyms, so I apologize for that. SWEEP is designed as an initiative within the executive branch some time ago, really to identify technology and other equipment investments that might be made in order to address system efficiencies and workforce efficiencies within state agencies. For that reason, it was never really sort of a single item like we bring typically. It says this is, one big item with a whole bunch of awards that are going to be made underneath it. This is an initiative that we have been involved with to the extent of reviewing requests from different state agencies, looking at them from the standpoint of eligibility under ARPA. And then determining which within those sort of fit the loose categorization that we set up for this initiative, and then if there are other funding sources that might be more adequate for some of these, they were urged to pursue those. So what you have today is a series of individual items from individual agencies, each with their own individual benefits. That are not necessarily part of a huge program, but are connected in that one sort of concept of improving efficiency and addressing potential workforce challenges in different agencies by using technology and equipment. I hope, does that help? I hope.
Are there questions? Representative Edwards.
Thank thank you, Madam Chair. Okay, so first of all, everything that you said just now makes perfect sense. I think it's a good initiative. I want to get to a layer or two deeper, though. And because there are so many separate projects taking place under this sweep umbrella, and they all generally have a similar objective of leveraging the technology to save manpower. It seems to me that there may be a need or benefit to having an identified program manager who crosswalks the executive branch to make sure that these projects are being done in an appropriate way, that there's metrics being established, that we're going to capture the manpower savings from anything we do, that somebody who really understands business process reengineering, the threat of applying technology to fix manpower problems is that somebody's may try to just substitute technology for people instead of redesigning the underlying workflow. So my concerns are kind of at the tactical level to make sure that we have a competent program manager identified who can crosswalk all of this and ensure the best practices of business process reengineering are being used.
Thank you, Representative. I would say, Gopher has not relinquished any of the role that it plays for any of these ARPA SRF funds in terms of making sure that there is compliance with the federal requirements that we are tasked with making for all of these programs. And as such, these are categorized within expenditure categories that each have within those their own requirements. So on that level, we are absolutely continuing to be engaged as we are with all programs that come before you that are funded for SFRF and work with those agencies to make sure that they are meeting those requirements. In terms of specific outcomes, I will say that, as it relates to this initiative called SWEEP, we don't have anything in place right now that would capture that sort of thing across the different agencies, just exclusively because, there are some significant differences in the types and then the goals of these types of programs. I'm not saying it's not a good idea. I'm just saying at this point, we don't have that plan in place necessary to capture it. Now, individual agencies, as they get these resources, should be able to be determine what those outcomes are along the lines of what you're describing as individual agencies.
Follow up?
So I have absolutely no concern about us being able to spend federal money so that we're checking the right box. Okay. I'm all about the second part of your response, which is how do we ensure the outcomes are really good, because this is a huge investment. It's at least a significant investment, and we really would like to see those positive outcomes. I'm just concerned that the decentralized nature of this non-existent organizational structure, we're not making sure that we have the right subject matter expertise spread across all the departments. And if we want in the future to be able to say, okay, we just spent $14 million or whatever the total is, would you please explain to us how that impacted our manpower requirements? I don't know that there would be a unified reporting structure under the current decentralized approach. So it's the outcomes and the subject matter expertise to ensure that we invest this money really smartly. But I think I've heard you. You don't have a centralized program management function at this point, but maybe it's an idea that you'll think about?
Absolutely. And, to the extent that we can work with the agencies to identify at least a couple of key indicators along the lines of what you're referring to, we would endeavor to do that.
Well, thank you for that. And so if you want to have informal, ongoing conversations, it's a topic that I did a little bit of at Phillips Medical Systems. I'd be happy to.
I'd welcome that,
Yeah.
Representative.
All right.
I'll
Thank you.
follow up with you. Thank you.
Are there any further questions? Yes, Senator Daniels.
I would have thought and I would have hoped that in the job description of our employees, the pursuit of efficiency would have been an ongoing thing. So I understand your statement about that we don't have a centralized one, but are we not trying to find efficiencies within a normal job description as opposed to spending this money?
Well, I can speak to the extent around the different initiatives under SWEEP, which are the goal of the program really, as we said, is for agencies to have identified where they feel that they could make some substantial improvements in the efficiencies for any given system with an investment of technology or equipment. It's not designed to displace any existing employees. It's not designed to, displace any existing workforce. It's designed to improve efficiencies. So, as it relates to individual job descriptions and how those are constructed, I don't really have a lot of say over that in different agencies, but your point is well taken.
Thank you.
Senator Rosenwald.
Thank you, Madam Chair. On a different but gopher issue, if I could, the Department of Health and Human Services has done a fantastic job planning for the end of the public health emergency when automatic continuous enrollment in Medicaid will end and people will have to be redetermined or lose Medicaid. What are we doing to plan for the end of the emergency rental assistance program in advance of, I don't even know when that's going to be, but my concern is about the clients and the local welfare budgets, which might be overwhelmed at the end of it if there is not thoughtful, planful wind down action. What are we doing?
Yes, ma'am. Well, we're obviously very close contact with HHS and with New Hampshire Housing and others as we go through this. We have a number of outstanding requests from the United States Treasury for additional funds under ERA 1 and ERA 2. We received information from Treasury just, I guess it was earlier this week, indicating that they would let us know in a few days whether there was going to be additional resource available under the program. So we're continuing, obviously, to monitor the amount of funding that's available and how quickly that's being expended with our partners at New Hampshire Housing. But yeah, I mean, we're all obviously very tuned into that issue right now.
Follow up.
Thank you. So would some of that additional funding be used to create a wind down process, or is it?
There would be additional funding. If we got additional funding, we would absolutely be able to put some of that into extending the services that are available for people as we come towards the end of the program. So that would be part of our plan.
Okay, thank you.
Yes.
Senator Daniels.
Thank you. There are three programs that have been outlined here with a statement that no federal funds will be sought for that. As far as the ongoing cost, after those systems are put in place, there's always an ongoing cost, whether it's maintenance for software or whatever. So what can we expect to see in the budget to support these systems that you are putting in place going forward?
It would be really hard for me to say, Senator, because these are individual agency items. the language that you're referring to, we would hold to that. There would be no more resource made available under ARPA for these types of programs. I think they're designed and submitted in such a fashion that the resources that they've requested under each of these individual items would be sufficient to complete the program. I mean, these are in most cases capital investments, infrastructure type investments, not operational. So I think that question probably would be best asked of the individual agencies, given those are the submitters of those items.
Okay, thank you.
Are there any? Representative Leishman?
Thank you, Madam Chair. Thanks for what you've given us already for information. But I guess in a follow-up to Senator Rosenwald's question, the LBA has prepared a document for us that they give us every month showing how much federal money we've received over the last biennium. And as you know, it's over $2 billion. Have you talk about, well, we're looking to get more federal funds into the program, but have you prepared something for the governor or anybody that what if none of this money is forthcoming? The state's going to have a huge hole to fill because this money is going to stop, as we all know. So have you prepared anything to warn us or give us the information we need going forward with the loss of these federal funds?
Well, I mean, I would say first off, I mean, with regard to the 2 billion, and I think probably in the end that number is actually higher than that, if you include CARES Act, it's a substantial amount of money. Obviously, it's all been pretty heavily bucketed, particularly under the ARPA funds, into many different types of buckets. So even within the ERA program and in the housing assistance program, we have ERA 1, ERA 2, and the Housing Assistance Fund, each of which have their own set of rules as to how you can spend that money. So the challenge that we have continuously had, and I've tried to, illustrate, is that due to the fact that each of these have their own rules and each of them have different funding timelines, each of them have outstanding requests of differing amounts of money, and we're not able to know from the federal government when they're going to provide any additional resources. While we do monitor, obviously, all of the funds that are available, it's difficult to say, these are the specific deadlines that we're facing right now. So, yeah, we've done a good deal of work with New Hampshire Housing at trying to predict when this outcome is coming. But again, because we don't have really solid numbers and timelines, it's hard for us to say, yeah, it's going to be on this date. And when we get that, we'll be able to do that, I would imagine, pretty quickly based on what we have available to us.
So I guess I'm concerned you say you don't have the availability because you don't know when these timelines are going to end. So you're saying the federal government has not been forthcoming whether these programs will be extended, or like I think we saw recently $40 million for rental assistance. If that ends, there are going to be a lot of people either out on the street or landlords not getting paid. I guess I'm concerned that we should have something more to prepare us for what I think may be difficult times ahead, because this money is going to end.
Right. And so there are deadlines on when we can spend the money. So ERA 1, if we get additional funding under that, we're going to have to spend that by December 30th. If we get additional funding under ERA 2, we have a longer time horizon, I believe out until 2023 or 5 for that funding. And in addition, as I mentioned to Senator Rosenwald, we're going to add more funding under those programs, assuming that we do get some, to continue the support services that have been ongoing already with people that are receiving funds under this program. It's not like they're just getting this money and they're sitting in their rooms. We're working with them to be able to continue to transition them off of the need for the assistance. And New Hampshire Housing and the CAPS have been doing a great job at maintaining that constant sort of churn. So I know we certainly would love to be able to say that there is a definitive point at which we're going to need to start thinking about how are we going to transition people. The fact is that we're constantly transitioning people, and that as soon as we're able to have some sort of sense as to when we're going to see any additional funding or not, then we'll make plans, obviously, based on that information.
Thanks. Thanks, Madam Chair.
Representative Edwards?
Thank you, Madam Chair. I just want to weave together my earlier comments with what Senator Daniels added, that on all of these IT systems, many places it says this is a one-time investment. And I think we should know that whenever you invest in IT, in the olden days, you had to budget like 18% of the acquisition cost every year for maintenance. So it's not a one-time expense. It's a commitment to a forever stream of expenses, maybe as much as 18% of the acquisition cost. And then someday you got to replace it. So because there's real money going out as far as the eye can see on these IT investments in particular, I just really think it's important for us to go into this initiative ensuring that we are influencing and reducing our demands on manpower. Otherwise, the money to pay for this 18% is going to have to become incremental. And that's where the bad budget outcome gets to be. So I just wanted to make that point, that it's really important that we do these programs right, because we're going to need to find the money to sustain them.
No, I agree, and that is the intent of the program, is to make these as close to one-time investments as we can. In fact, as you've heard me say before, in almost every one of the programs that we bring under SFRF, that's sort of the one of the main points that we're trying to stick to in the types of items that we're bringing, is that these are one-time investments for the most part.
Are there further questions? Thank you very much.
Okay, thank
Okay.
you.
We conveniently took FIS 22-351 off the consent calendar in order to hear what the Gopher office had to say about these programs. So could I have a motion to thank you, Senator Bradley. Do I have a second? Second, Senator Susie.
Madam Chair, can you please explain what the motion is?
Oh, we're going to accept FIS 22-351.
Okay, thank you.
Sorry.
Roll call on 351. Representative Edwards.
On 351, yes.
Emmerich votes yes. Representative Erf.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley. Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susie. Representative Umberger.
Yes.
Madam Chair, the vote is 10-0.
The vote being 10-0, FIS 22-351 is approved. We now go to FIS 22-359. Governor's authorization to accept and expend $20,022,503 in SRF funds. I believe that someone in the Senate had questions about this item. Is there any? Pardon? Oh, okay. All right. So no questions. All right. I thought there were questions dealing with how the community centers were going to get word of this, but okay. So Senator Rosenwald moves 22-359, seconded by Representative Leishman.
Roll call on 359. Representative Edwards.
Yes to 359?
Emmerich votes yes. Representative Erf.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley. Yes. Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susie. Yes. Representative Umberger.
Yes.
Madam Chair, the vote is 10-0.
The vote being 10-0, FIS 22-359 is approved. We now go to FIS 22-361, which is a request for $8,883,875.
Madam Chair?
Yes.
Somewhere in here, I think we agreed to bring forward the information item on vaccines. And if we're talking about 361 now, then I think we maybe want to consider Dr. Chan and Ballard's paper.
That's
Okay.
fine.
I think we're confused. What would you like to hear first, 361 or the informational item?
The informational item.
Okay, thank you.
Changing chairs is always fun. It's okay.
This is a great time. Thank you.
Do you mind if I sit in the center? It's just
Go ahead.
Apologies, a little musical chairs there.
Oh.
So, Madam Chair, members of the committee, thank you for the opportunity to come before you this morning to talk about, I think, the important issue of COVID-19 vaccinations. For the record, my name is Ben Chan. I am the state epidemiologist at the New Hampshire Department of Health and Human Services.
Could you pull your microphone closer, please?
Oh, I apologize.
That's okay.
I was just saying that I am the state epidemiologist at the New Hampshire Department of Health and Human Services, also an infectious disease, internal medicine, and preventive medicine physician. Several weeks ago, I got a request, I believe from some members of this committee wanting to know more about the science and specifically the scientific studies that have been used to back up COVID-19 vaccine recommendations. And so over the ensuing couple of weeks, I developed this 3.5, 4-page New Hampshire science brief about the safety and effectiveness of COVID-19 mRNA vaccines. I understand that the request was primarily focused on data for children, but I did include in the science brief all data that we have been reviewing over the course of the pandemic for children, adolescents, and adults, partly because that data is important for informing also what, for seeing the consistent trends in vaccine safety and effectiveness, and all data has been used to inform COVID-19 vaccine recommendations. And so while this looks like a long report, the actual text, the actual science brief of it is only about 3.5 pages. The rest are scientific references pointing to peer-reviewed journal publications in reputable scientific journals. I did not include any preprint publications, which are studies that have been written but have not yet gone through the scientific review process by peer reviewers and editors. And so this scientific brief really focuses on those reputable scientific journal publications that have come out around vaccine safety and effectiveness over the last couple of years of the pandemic since we've had COVID-19 vaccines available. So I believe this has been circulated ahead of time, but wanted to be available to answer questions you may have about this science brief that we developed or questions about COVID-19 vaccines in general. Thank you.
Thank you. Your paper was very good. Probably some folks didn't agree with your conclusions, but that's the way it's been with COVID-19 and science or whatever. So don't.
Thank you.
It's okay. We all, in this case, there are many different opinions. But I believe, Representative Edwards, you had some questions for Dr. Chen.
I do, Madam Chair, and I'm not. Just to clarify, my questions are related to, the processes that we use within the Public Health Department. I'm not challenging the conclusions of Dr. Chan. I just want to make sure that the public confidence is inspired by the outstanding clinical research capabilities we have in the department. And so in order to highlight them, I have maybe about 5 questions or so. I think what people heard when they heard the saying that we should be following the science, what they thought that meant was that there would be good clinical research done before a policy, governmental policy mandate was imposed. And I think a lot of people got concerned because of the perception that we weren't following the science. We were sort of reacting to the instincts of a select number of scientific people. So I really am very glad that you've come out with this paper, because I think this is a sort of the first time we've put a stake in the ground saying, here's the science, and this is, and therefore this is our policy. Would you agree or disagree? Would you say it differently?
Yeah, thank you for that question, Representative Edwards, because I think it's an important point to make, is that we never and have never throughout this pandemic just accepted recommendations coming from the federal government, and particularly around when it comes to medical recommendations. One of the key roles of myself and several other clinicians in the department is to review the science ourselves. And so that's what we've done. And so the compilation of the science memo actually is from studies that we have collected and reviewed in New Hampshire, studying and looking at and reviewing the studies that have come out around vaccine science and the safety and the effectiveness of the COVID-19 vaccines. So that's where these 120 plus references came from. These are all studies that we have reviewed over the course of this pandemic, and have been used to inform our adoption and support for a lot of the COVID-19 vaccine recommendations that are out there. But this applies to other areas of COVID-19 response as well, not just COVID-19 vaccines. We've always reviewed the science and have, which has informed our approach that has sometimes deviated from federal guidance on a number of matters. But when it comes to COVID-19 vaccines, I think the data and the science is overwhelmingly clear. Multiple studies, as I highlighted in this report, that the vaccines are safe even for children and maintain high effectiveness, particularly against more severe disease and also long-term complications of COVID-19, which I also highlight in the science brief. The only other point I wanted to make is that at a federal level, I think people need to be aware that it's not just federal politicians or bureaucrats, so to speak, or federal employees, I should say, that are coming out with these guidelines and recommendations, particularly when it comes to vaccine recommendations. And this is one of the key roles of what we call ACIP, the Advisory Committee on Immunization Practices, which helps to create all of the recommendations for all childhood vaccination series. These are not federal employees. These are a group of medical professionals, people with expertise in vaccines, who come together to review the science and to make determinations and make recommendations about vaccine recommendations. It's a medical group. So the ACIP supports the federal guidance that comes out, helps to develop that federal guidance. So it's not just federal employees or federal politicians that are coming out with the guidance at a federal level, but certainly at a local level, we take our responsibility for similarly reviewing the guidance seriously, similar to what the ACIP does at a federal level.
So would you agree that any of these studies should be subject to a scientific method? And what I consider the scientific method, and you could educate me if I'm wrong, is that a hypothesis gets identified, a research trial is put together, the data is gathered and analyzed, and the key to good scientific inquiry is repeatability, and with repeatability comes the a power or the opportunity to refute and disagree with the results, to challenge the scientific inquiry process. Would you agree or say it different about the scientific method?
Yeah, I think the scientific method has been proven over and over again to be important and reliable, and part of that is defining what you're studying, and then the study outcomes, and that does need to be repeatable. And so I think what we have seen with the COVID-19 vaccine literature, the scientific publications is, and I tried to highlight this in the science brief, over and over again, multiple studies have found consistent findings both between adults and children, and across multiple studies of repeatable findings that these vaccines are safe and effective. I will also say that there are differences in quality of studies. So it's not just about any one particular study. It's about the type of study. Is it a randomized, double-blinded, placebo-controlled clinical trial, or is it what we call a higher-level ecological study that has, usually we have lower confidence in findings of studies that are not well-designed or not as rigorous. So this highlights, I think, the importance not only of the study and study design, but also to what you say is the repeatability of those findings.
Well, thank you for that. So that takes me to the Florida question, which is evidently I'm a layman. I've worked around academics, so I kind of understand what they've done, but I've only been in a support role. But as I've taken a look at what Florida's coming up with and the kind of guidelines they're coming up with the demographics of kids 6 months and older, the demographics between, I don't know if it's 5 to 11 or 5 to 17, I forget the end point. And then even recently they said men ages 18 to 39, that none of those three demographic groups really ought to be thrown into the category of default taking of the COVID shot. And because their conclusion is so much different than our own. In 361, we make a very categorical statement on page 3 that the department recommends that all persons 6 months of age or older complete the COVID-19 primary series and booster vaccination when eligible. So our conclusion is very strong and very different than Florida. And so can you explain, the extent to which you look at contrary opinions and you use it to, second guess yourself, not so that people like me aren't second guessing you, but that you've got your own process?
Yeah, Representative, thanks for that question. And I think it's an important point and an important question to make because there has been a lot of confusion, and I think there's been multiple instances where I think the public in general, even providers have been confused because of differing recommendations coming out from different states throughout the pandemic, not related necessarily to COVID-19 vaccines. I will say that when it comes to COVID-19 vaccine recommendations, I am aware of Florida's guidance. It was sent to me ahead of this meeting, so I did have a chance to review it, particularly for their guidance for pediatric COVID-19 vaccines, which I have in front of me here. I printed it out. They're in the minority. I am not. My understanding is that the vast majority of other public health jurisdictions across the country, are in alignment and in agreement with the guidance and the recommendations that have come out from the CDC and ACIP, the Advisory Committee on Immunization Practices. And it's not just adopting these guidelines from the feds by default. There's science to back it up. When I looked at Florida's guidance, my concern is that this is not appropriate guidance. It's not appropriate medical guidance because it's not evidence-based guidance. They reference several studies in their guidance, but if you actually click on those studies and go into review and see what those studies are actually saying, those studies are not actually supporting their conclusions. And so this guidance is, in my opinion, not evidence-based and is not backed up by the vast majority of the science out there, which has shown vaccines repeatedly to be safe and effective. And the conclusions that they're drawing from some of the studies that are linked in their guidance is just simply not appropriate. And so just as an example, one of their points in which they sort of come out less strongly, if I can put it that way, against COVID-19 vaccines in kids, they talk, one of their bullet points here is limited risk of severe illness due to COVID-19 in children. And they reference a study, but that's not actually what the study is studying. If you click on the link, the study that they reference is about the evaluation of the Pfizer vaccine in children 5 to 11 years of age. So you can't actually draw that conclusion from the study that is referenced. In order to look at severe illness from COVID-19 in children, you need a study that's designed to look at severe illness in children and not studying vaccine effectiveness in children. And actually that study's conclusions are that the Pfizer vaccine in children is found to be safe, immunogenic, and efficacious in children 5 to 11 years of age. So that's just one example where I don't think that Florida's guidance is evidence-based or appropriate based on what they're referencing here for studies.
So just to clarify, somebody may misinterpret your initial couple of sentences to imply that it's majority rules on science, and I don't think you meant to say that at all. You just
No,
gave us an
correct.
extremely long explanation of the body of the evidence and the number of repeat examples. So I just didn't want you misunderstood about majority rules on scientific issues. Now, earlier today, I had a chance to chat with Dr. Ballard and Ms. Tilley, and they pointed out multiple instances where the department has differed in its opinions from what the CDC was promulgating. And I think that's kind of an interesting topic because it may help demonstrate sort of the independence of thought and the thoroughness of what we're investing into the process. Can you maybe give us an example and talk about sort of New Hampshire as an independent thought leader in this area?
Yeah, thanks for that question. Would you like examples just related to COVID-19 vaccines or other examples?
Let's stay on topic. Just
Okay.
and if you got a 6-month-old example, that would be really great. But you probably don't.
Yeah, thank you for that. Thank you for that question. And I think there have been multiple examples throughout the pandemic where we've differed or come out with our own guidance all throughout the pandemic, either because the guidance wasn't there at a federal level or it wasn't there on time or we disagreed with it. Relative to vaccines, I think there are a number of instances throughout the last 2 years of the pandemic. Maybe the first example I'll point to is going back to January of 2021, if I can go back that far in my memory, when vaccines had just started to roll out. We had focused vaccines for those at highest risk for severe disease and older adults who may, and healthcare workers who were on the front lines. And just one example of applying vaccine science to our guidance, there was an intense discussion come January about whether we were going to still require people who were fully vaccinated, who had gotten the primary series, to quarantine after an exposure. And we in New Hampshire were pushing hard for that, for the federal government to take the step of not, recommending quarantine for people who are fully vaccinated to quarantine for a few reasons. One, because the data at that time was showing that the vaccines were highly effective at preventing disease, like 95% effective at preventing disease. And with a vaccine that's that effective, we didn't see a need to still, require people to quarantine. We're actually one of the first states in the country to come out and make the recommendation that people who are fully vaccinated were not required to quarantine after an exposure. And it took the federal government, the CDC, 1 to 2 months longer to come out with that recommendation. For whatever reason, I can't speak to exact, but we were having discussions with CDC about the time about this around the time, but that was one of the earliest examples of, we were looking at the vaccine science and the vaccine data and using it to inform our approach and recommendations. One of the earliest of which was not requiring people to quarantine after an exposure. Right around the time of vaccine rollout, the federal government was coming out with guidance about who should get vaccinated first. Particularly with limited vaccine. New Hampshire, as with many other states, came up with their own strategy. We had a whole team working on vaccine allocation strategy. More recently, with the rollout of the Omicron boosters, so the recommendation now is that as long as somebody is at least 2 months, and this is a little bit of a detail that maybe is not that important, but highlights the example. The recommendation has been that people who are at least 2 months out since their last dose of the vaccine, the older version of the vaccine, are eligible for one of these updated Omicron boosters. That's a detail in the recommendation that I generally don't agree with. I think that's too short of a time frame. I don't think there's a safety concern with somebody getting vaccinated 2 months after their last dose. I just think it's unnecessary and it doesn't optimize the effectiveness of the vaccine. And so we have put out guidance in some of our health alert network messages and publicly suggesting that people wait, a longer period of time between infection or prior vaccination and getting one of the updated Omicron boosters in order to optimize the protective effect of these updated booster doses. So those are just a few examples, some more pertinent and relevant than others.
All right. So we're spending a lot of time in a fiscal committee on this, but I think it's worthwhile because we're coming out of 2.5 years of the pandemic, and this is really the first example that I can recall where we've published the science to the public and said our policy is supported by the science we're sharing with you, which I hope in the after action review is annotated as something for the future, that we are more proactive in getting the science put in front of the public so they can understand any of the policies we're implementing. So with all of everything you've said, my concern is still on page 3 of 361, and there's a particular sentence in there that I just want to make sure that you agree and support it. And I think Ms. Tilley can stick her finger on it. The New Hampshire Department of Health and Human Services recommends that all persons 6 months of age or older complete the COVID-19 primary series and booster vaccination when eligible. A reformulated booster, which is currently available to individuals 12 years of age or older, will offer enhanced protection against COVID-19. Is this possibly an overpromise, too strong a recommendation, or do you stand by this literally?
Can I see the wording again, since you're asking about literal? What is there a specific section there that you are concerned about?
Well, I just read it. It's from page 3 of 361, down underneath the table, underneath the term vaccination and testing services. There's a 2-sentence paragraph.
Yeah. So yes, I think we stand by that recommendation. Certainly there are some minority of people that may not be eligible to get the vaccine because of a medical contraindication. Certainly those people shouldn't be vaccinated, and there's guidance for who shouldn't get vaccinated. But everybody else, it continues to be our recommendation that everybody else 6 months of age and older be vaccinated. Now, I do want to acknowledge that certainly children are at lower risk for severe disease, severe outcomes from COVID-19, but it's not true that they're at no risk. And so I think that the data, even in children, consistently shows that vaccine, even in otherwise healthy children, vaccine offers important protection against COVID-19. Against COVID-19 in the short term, we're talking over several months, over protection against severe disease in the longer term, and then potentially, protection against some of the longer term complications that can arise from COVID-19. I mean, we're seeing more and more studies come out, for example, showing an association between COVID-19 disease, COVID-19 infection, and diabetes, right? I mean, diabetes is a lifelong medical complication. Now, we can't predict who's going to come down with complications of COVID-19, right? Some people will get COVID-19 and have very mild illness and get over it and have no problems. Other people can have COVID-19, children included, develop multi-system inflammatory syndrome, end up in the hospital, die, get long COVID, develop diabetes. Certainly the risk of that happening in children is lower, but we can't predict who's going to develop those complications and who isn't. And the data in adults and adolescents and children has been clear that the vaccines are safe, the vaccines are effective, and that any potential side effects from the vaccines are usually short-lived due to the body's reaction to the vaccine, and that the benefits of vaccination, even in children, outweigh potential side effects.
Thank you, Madam Chair, and thank you, Dr. Chen and your colleagues for your service to the state. I appreciate you working on this so hard and sharing it with us. Thanks.
My pleasure. Thank you for your questions.
Are there any further questions? Senator Bradley.
Thank you very much. So going back to what you told the Health and Human Services Committee several months ago, Ms. Tilley, obviously the department recommends, but there is no initiative on the department's part to go forward with a gel car application to require a vaccine for school-aged children or children attending daycare. Is that still correct?
Thank you, Senator Bradley. That is correct. We are not moving forward with any recommendation for mandatory vaccine for COVID-19 for school or childcare entry.
Thank you.
Can I, I'm sorry, Madam Chair, and if I can also comment, there was forget the committee that this question has come up at about school requirements for vaccines that I think we had a similar discussion at. I just wanted to add to what Director Tilley said that the COVID-19, it's looking like the COVID-19 vaccine will turn into probably an annual booster. Right. I mean, the science, the data is still out on that. But it's not the type of vaccine which we would require or add to the required list for childhood vaccination series for entry into school or childcare, partly because we're expecting it to turn into an annual vaccine. Just like we don't require the flu vaccine every year, there's no plans at this point to add the COVID-19 vaccine, which is looking like it's going to be an annual vaccine, to the required list. Both because of the properties of that vaccine and just the logistical hurdles of trying to have a school verify a student is vaccinated every year is just not possible.
Senator Daniels.
Thank you. Dr. Chen, on the references that you provide of the 125 references, are they all supportive of your position, or are there some in there that are contrary to your position?
Well, so the references are linked to specific statements throughout the document, and so those references are supportive of the statements that are made throughout the document that the references are linked to. I think the overall conclusion also of those studies is supportive of what I've already said.
Okay, I'm not sure you answered the question. So in the references that you provided here, they are supportive of your statement that's saying that vaccines are safe and effective. My question is, are there studies that you looked at that you have included in this list that say they don't believe that statement?
I would have to pull up specific studies, but I'm trying to think back through the studies. No, I think the studies are all, particularly around vaccine safety, are all supportive of that statement.
Okay, thank you. And
if you have a specific example that you find, I'm happy to sort of review or talk through that study. But again, it's pulling from my memory here.
Well, I think the chair started out by saying that people have various opinions on vaccines. So, I wondered if we're looking at a paper that's got 125 references that are basically going to be lopsided versus there may be other studies in there that have an opinion that is contrary to the statement that they are safe and effective. For instance, how do you explain to someone whose child has had adverse effects by having a vaccine, even to the point of dying, by telling them that it's safe and effective?
Yeah, and thanks for asking that question, because I think it is important to separate science and studies from opinion. And so I certainly recognize the fact that different people have different opinions. But again, I think the data here supports vaccines being safe. I know that the question of well, I think partly this comes back to some of the Florida guidance that was out in the news recently, where they did a very high-level crude analysis of some of their death data, which I think inappropriately suggested that there was a higher rate of death after vaccination. And again, this is where it's important to sort of look at the study and look at the science behind it, because that report is not the kind of data that would, I think, ever get published or make its way into a scientific journal, just because of all the problems behind that analysis. When it comes to questions of COVID-19 vaccines and safety, what I will say, and what we have said all along, is that there's not evidence of some excess number of deaths related to vaccines that I've seen. Now, there are people suggesting that, but I don't think that that's backed by science or data. And in fact, any death that occurs after vaccination, for whatever the cause, is required to be reported into VAERS, which then gets investigated further. And so it's not just about doing, high level, medical record system analysis. It's really about diving in to understand the cause of death. And what's been found in reviewing that data is that, people that are reportedly dying after vaccination are not dying from, the vaccine themselves. A vast majority of them are getting vaccinated and then dying from other causes, or even COVID-19 itself. So a lot of the wrong information that's out there about all these deaths from vaccine are not actually deaths from vaccines themselves. That's data that is poor quality data, or data that's being misrepresented or misinterpreted to back someone's opinion or concern.
How are we supposed to believe in scientific data? And I'll use your point because it was right on, where particularly we saw individuals in nursing homes that had comorbidities. They came down with COVID there. Their death certificate revealed that the death was COVID, not the other. So, I think there's a certain number of people who believe that those numbers were skewed to make it seem like COVID was worse than it was versus having the other comorbidity. So, how are we as legislators supposed to understand and believe what is actually the truth?
Yeah, another great question. And I think your concern gets at the question of how we conduct death surveillance, particularly around COVID-19. And this is, I think, another area of confusion, because different states have done it different ways all throughout the pandemic, and you've heard reports coming out from other states. I will say that in New Hampshire, I can speak for New Hampshire, we rely on the death certificate. The death certificate is a formal, objective way of assessing deaths from any disease. It also relies on the healthcare provider who's pronouncing the person as having died, a healthcare provider assessment as to the cause of death. And so we're not, the public health agency, the New Hampshire Department of Health and Human Services, is not the agency that's vetting and assessing whether somebody died or not from disease A or disease X or COVID-19. We're relying on that healthcare provider assessment to help make that determination. And not only that assessment, but that assessment as documented in the death record. And so if anything, at least in New Hampshire, our assessment of COVID-19 related deaths is likely an underassessment. Now, other states have done it different ways, which has been in the media over the course of the pandemic, with people voicing concerns about overestimating COVID-19 related deaths. But that's not the case in New Hampshire. We've always taken a much more conservative approach to classifying COVID-19 related deaths. It's very similar to how we track other deaths from other diseases like influenza. And so again, I think we've tried to come up with a process that is relies on the existing systems we have in place, is similar to how we track other, infectious disease related deaths, and relies ultimately on that healthcare provider assessment as to the cause of death.
Thank you, Madam Chair.
Senator Rosenwald.
Thank you. My questions are about the telehealth part of this item. I'm trying to understand the process of how this works. So if I do a home test
Yes.
and it's positive, am I able to then access this telehealth program? And is my insurance going to cover the cost of the Paxlovid
Sure.
if I'm eligible, or is the money we're appropriating today going to pay for that and my insurance company won't be billed? Or do I have to go somewhere and get a PCR test?
Great. Thank you very much for that question, Senator Rosenwald. So we are envisioning this program similar to a program that was done in Massachusetts. So again, I'm home, I'm sick, I have a rapid antigen test, I test positive, I may be at risk for poor outcomes. So you can call this entity. We will put a contract through that'll go through Governor and Council for a healthcare entity who will be available 24, well, maybe not 24/7, but certainly 7 days a week to be able to take you in and do a medical evaluation and look at your test that you tested positive. They may ask you to take another test, but I think they will document, you show up, yep, I tested positive, and they'll go through and ask several questions and assess whether or not Paxlovid or another therapeutic is right for you. Assuming it is, they will have two options. One, they could send that directly into your pharmacy. So if I go to my Colonial Pharmacy in New London, New Hampshire, they can send that script in and I can have someone go and pick it up for me. If that won't work for me because I'm homebound or I don't have anyone to go out to the pharmacy for me, we can arrange for it to be overnight shipped directly to your home. The question around insurance is an interesting one because at the federal level, currently Paxlovid is covered. It is by the federal government, so it is free at this moment. That may change in the future, and we want to build in flexibility within the contract to ensure that we can cover that for an uninsured person. We want to make sure that the telehealth visits are available to anyone appropriate 18 and over, and have it to be free and no cost to them. Is there anything you'd like to add, Dr. Ballard?
No, that's very accurate. And so Jonathan Ballard, Chief Medical Officer for the department. So currently, the Paxlovid is being directly provided to pharmacies from the federal government. And so when you get it, pharmacy may charge a dispensing fee potentially. They're allowed to, but there's no charge for the drug itself. Also, the federal government has provided the Department of Health and Human Services in New Hampshire a supply of Paxlovid that we will provide to the contracted vendor for the medication that would be directly shipped or overnighted to those that are homebound.
So this sounds like it's a money saver because if I do a home test, I don't have to go to one of those for-profit urgent care centers that are going to do a whole workup and charge me a big copay and a coinsurance to make sure I don't have anything else going on, right? There's
Absolutely. I think
no charge for using that telehealth
No
service.
charge for using the telehealth. And I think that that's one of the benefits of this program. Again, as we get through this winter surge, I have shared my personal story. I had COVID recently, and when I called my primary care physician, they said, go to the emergency room. I was actually feeling so poorly, I did not want to go to the emergency room. And again, urgent care said, come on in. I didn't feel like that was the right path for me. I waited until I could go to a pharmacy that also has a federal program called Test to Treat, but really not many people know about that, and it's really complicated. So we want to make this easier for people, especially in rural areas, especially people who may not have a strong relationship with a primary care provider who test positive on a Saturday morning and don't want to wait several days.
And finally, I mean, I think this sounds like one of the best ideas I've heard in a long time. Thank you for doing it. When will this program be up and running, and how are the 1.4 million people in New Hampshire supposed to know about it?
A couple of components to that. So we will identify, we're in procurement process with a potential vendor. It will go to governor and council very soon. Whenever it is performed with governor and council, we fully expect that this type of a program with a potential vendor would be implemented very fast. Now, some programs like staffing surges and those take time to implement, but this is not something that will take an enormous amount of time to implement. It would be within weeks or days of the governor and council meeting. And if I just may add, the investments that this committee has made over the last couple of years, these very targeted projects like this, I think is what distinguished New Hampshire as well in so much of our good response. Senator Daniels has asked in the past for us to bring data back when we bring programs forth like this to say, to justify what we've done in the past and these types of programs. There was a recent report from the Commonwealth Fund in June of 2022 that looked at throughout 2021 and up until March of 2022, all the states and the amount of excess deaths that each state encountered from all causes, including COVID. And there was only one state that had less excess deaths than New Hampshire, and it was Hawaii. But we had the second least excess deaths from COVID, from opioid overdoses, from chronic disease deaths compared to any other state. And I brought that along with you, just so you know that these types of targeted investments that we've done and going forward, not causative, but suggestive, have made a difference.
And to follow up the last part of how will people know, it is built into the contract that they will have to do some advertising and maximize that the vendor itself will do advertising, and we'll certainly amplify that through the department through our communication means as well.
Representative Emmerich, do you have a question?
Thank you, Madam Chair. My question is more of curiosity rather than this specific discussion about the vaccine. I was an early adopter and got COVID in 2020. Took me out of the commission for about 3 weeks, and thankfully I lost 20 pounds, which I've gained back, but that's a different story. The problem I've had, the issue I've had is there's been no recognition of actually contracting the disease and your protection. It's like devoid of any value that you actually had COVID. And I'm just curious, why isn't there anything that says, well, if you've already had it, maybe you only need one booster instead of two, or anything, just some kind of recognition.
Right. Thank you, Representative Emmerich. So that actually is something we do have in our guidance. And there's a time period after having contracted COVID-19 that we actually say, and Dr. Chan referenced this earlier, that we would recommend delay getting the booster vaccine until a time period passed by. I think Dr. Chan's at 90 days?
90 days.
90 days. And so after that time period, we actually do recommend that, to wait that time period and then get the vaccinations, because you're at less risk of contracting COVID for those first 90 days than afterwards.
Yeah. Okay. Are there any further questions? Okay. Senator Bradley moves, seconded by Senator Rosenwald. Will the clerk please call the roll?
On 361. Representative Edwards.
Yes to 361.
Emmerich votes yes. Representative Erf.
No.
Representative Leishman.
Yes.
Representative Daniels.
No.
Representative Bradley.
Yes.
Representative Gray.
Yes.
Representative Rosenwald.
Yes.
I'm sorry. Senators, my apologies. I was on a roll with Representative. Senator Rosenwald.
Yes.
Senator Susi. Representative Umberger.
Yes.
Madam Chair, the vote is 8 yes and 2 no.
Okay. The vote being 8 in favor and 2 opposed. FIS 22-361 passes. Okay, we now turn to, oh, by the way, Dr. Chan, thank you so much for your presentation. And I believe that it has provided a lot of really good information to the committee, as well as to anyone that might be watching it on YouTube. So thank you so much for that. Okay, we now turn to FIS 22-362. authorization to expend $228,228. Oh, wow. So that's pretty interesting. Okay, Representative Edwards.
Thank you, Madam Chair. Hopefully this is more in the lines of yes or no. This looks like it's a request to buy a particular form of a test, and it's specifically written up for COVID. And I'm just curious if there are tests that would fall under this sort of funding authority that would be more robust in its testing. I mean, people used to die of flu. Are we gonna use this, or is there anything we can buy that'll test for more than one thing?
Thank you, Representative Edwards, for that question. So as the pandemic has progressed, new technology, new therapeutics has emerged to allow us to mitigate the effects of it. And this is one development that we want to implement for those persons that we serve at our 24/7 facilities. So a PCR test is a test that is a gold standard type of test that is for both symptomatic and asymptomatic persons. Now we have those tests that are rapid on site that can be done at the actual facility, not having to be sent off to a lab. Also, now the tests are available to be done through saliva samples and not a nasal sample. So this is sort of the latest latest thing that is FDA emergency authorized approved, and what it can do for us is very unique situations. I was speaking with the commandant of the New Hampshire Veterans Home. For when one of our veterans may contract COVID-19 and they have a roommate who's asymptomatic, this will be a particular test that roommate can have that will be highly accurate, immediately allow her to make the commandant to make those decisions of whether or not that we need to move the patient to another room. And so there is no other flu vaccine or flu test that is like this yet. All of those tests have to be done in a commercial laboratory. So this is sort of the latest technology that's available, but is not able to be combined with other types of tests, such as testing for flu.
Okay, that last sentence was what I was looking for.
Sorry.
Thank you.
Okay, Senator Daniels.
Thank you. Over the past few months or years, we've spent a lot of money putting it into testing stuff. What do we have for current reserves on those things?
Zero for this type of technology. This is a new type of technology that allows us to make better decisions for our veterans and other persons that it will benefit. So we don't have any. We have rapid antigen tests, but those take some time to develop positive results or negative results after exposure to the virus. So this will be allow us to make decisions sooner, and we have zero supply of this.
Okay, thank you.
Are there any further questions? Thank you. Representative Leishman moves item FIS 22-362. Do I have a second? Second by Senator Susie. Will the clerk please call the roll?
Roll call on 362. Representative Edwards.
Yes to 362.
Hamrick votes yes. Representative Erf.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley.
He's absent. He stepped in.
Oh, I'm sorry.
He'll be back in just a minute.
He'll be back.
Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susie. Representative Umberger.
Yes.
Madam Chair, the vote is 9-0.
The vote being 9-0, FIS 22-262 passes. Or 362. Okay. Next, FIS 22-363, which is authorization to accept $750,000 in ARPA money. Welcome. Could you identify yourselves, please?
David Wieters, Information Services Director, DHHS.
Good morning, Karen Heber, Director of the Division of Economic and Housing Stability.
Thank you. Does anyone have any questions on this? Because I do, okay? If no one else does, I'll just ask my questions. My concern is, when do we anticipate Medicaid enhancement ending?
That is a great question. So just yesterday, the Secretary of the U.S. Department of Health and Human Services just renewed the declaration of the federal public health emergency for another 90 days. So we are anticipating that it could certainly end January 12th would be that particular date. We expect that we would get notification of that from the White House 60 days in advance of that date. So we're looking at hopefully knowing more information by November 12th. The continuous enrollment, if it were to end January 11th, the continuous enrollment would end January 31st.
Okay.
February 1st would be the first date that coverage could be terminated. And then the enhanced FMAP of 6.2% would end March 31st.
So if I understand what you just said, we have no clue.
That's correct.
Okay. Well, I just thought I'd ask. And how many people are currently on this program?
So currently there's 243,238 individuals, I need my glasses, who are enrolled in Medicaid, and that's individuals. The protected status, the protected number of individuals currently is just over 96,000. And those are the individuals who are at risk currently of losing their coverage.
Okay. That's all. Does anyone else have any question? Representative Edwards?
Thank you, Madam Chair. So this is actually a good example of the conversation I was having earlier with Mr. Caswell, that we're looking to use technology to make us more efficient and do with fewer manpower, less manpower. So do we have the skill sets to go in and make sure that we're not just substituting technology, that we're actually looking at a redesign of workflow to leverage the technical capacities? Or in other words, are we really going to take advantage of the opportunity to fundamentally improve the system? And by that, I mean more than the IT system.
Certainly. That's a good question, Representative Edwards. So in preparing for this item, the department, in conjunction with the incumbent vendor, looked at the solution that we're looking at for New Heights. And the goal is to use that funds to do that business process management or re-engineering to allow for the manual processes to be replaced with the automation. This will allow those people that would be otherwise impacted pretty heavily by 95,000 people potentially losing their eligibility to focus on providing the services and providing the continuous operations of the system. If we don't implement this solution, the staff would be overwhelmed with potential eligibility appeals. So this is really, to answer your question, is part of that business process management. We identified this as the only way we can really address the potential public health emergency unwind. effectively. Did that answer your question?
I think you brushed up against it. I'm more concerned at this point in the quality of the business process reengineering and whether or not we have access to the skill sets. If we think we're going to actually do a redesign of the workflow and then support that new workflow with the technology, or if we're just more going to try to substitute technology for people.
So thank you for the clarification. So we are looking at simplifying that workflow with the use of this technology. So they're really the additional skill sets that really isn't necessary. We really have the skill sets already. So the enhancements would automate some of the process. It would also assist staff to manage it much more simplified. Currently, it's entirely manual. So when requests are received for an appeal, there is a great deal of manual pulling of information and putting together notifications for the administrative appeals unit, making sure all that is done in a timely manner. So this is to basically increase the capacity of staff and reduce that workload with each of the types of tracking methods that we're looking at implementing.
I do have one further question. Of the 93,000 or 96,000 folks you're talking about, what's the percent of children versus adults?
Currently, the number of children, or this is as of earlier in the month, is 33,227.
So the majority of these are adults. Yeah, 2/3. Okay. All right. Okay. Could I have a motion to accept on FIS 22-363? Senator Rosenwald, second. Second by Representative Erf. Will the clerk please call the roll?
Roll call on 363. Representative Edwards.
No on 363.
Representative Emmerich votes yes. Representative Erf.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley.
Yes.
Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susie.
Yes.
Representative Umberger.
Yes.
Madam Chair, the vote is 9-1.
The vote being 9-1, FIS 22-363 passes. Okay. Turn now to FIS 22-366. We're still in tab 8. Someone had some questions on this? Yes, Senator Rosenwald.
Thank you. We had asked the department to respond, and I think you have, but I wanted it to be said publicly. There is not a clawback if somebody loses Medicaid eligibility after the end of the public health emergency. But there have been claims submitted. They would not be responsible for repayment to the state or the federal government.
For the record, Henry Littman, the Medicaid director for the state. Thank you for the question, Senator. We are protected as long as we made the eligibility determination correctly, and we have a high degree of that.
Did you have? Could you repeat that? It didn't sound like a complete sentence to me. I'm sorry.
Thank you, Representative. Madam Chairman.
I got that.
Sure. What I was explaining that is if we incur costs for someone during the continuous eligibility period, we're protected against a clawback as long as we made the original determination of eligibility correctly.
Okay, that, thank you. I guess my ears weren't listening well.
I probably need to speak up. louder. Thank
No,
you.
that's fine. That's fine. Are there any other questions? Representative,
Yes, you know what, I think you may not have completely answered Senator Rosenwald's question. I think she was also asking about beneficiaries. In other words, if a beneficiary, is there any provision for a clawback that the beneficiary who improperly, and I'm not saying fraudulently or anything like that, but if they applied for benefits, they were awarded, and then it's determined that they shouldn't have, that for some reason they shouldn't have received them, is there a clawback provision that they have to pay back?
My understanding on that would be no.
Thank you.
are there any further questions? Seeing none, Senator Rosenwald moves. Do I have a second? Second by Senator Susie.
Roll call on 366. Representative Edwards.
Yes on 366.
Emmerich votes yes. Representative Earp.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley.
Yes.
Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susie. Representative Umberger.
Yes.
Madam Chair, the vote is 10-0.
Vote being 10-0, FIS 22-366 passes. We now turn to tab 10, the regular calendar. The first item on the agenda is FIS 22-341 from the Department of Safety, which is requesting expending $638,600 in other funds from prior year carryover. Did safety run away?
Good morning, Madam Chair, members of the committee. Steve Lavoy, Director of Administration for the Department of Safety.
Okay. Are there any questions on the request for prior year carryover spending? Seeing none, Representative Leishman moves FIS 22-341. Do I second by Senator Susie?
Roll call on 341. Representative Edwards.
Yes on 341.
Emmerich votes yes. Representative Earp.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley. Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Oh. Senator Susie. Representative Umberger.
Yes.
Madam Chair, the vote is 10-0.
Vote being 10-0, FIS 22-341 passes. Thank you. We now turn to tab 11, which is FIS 22-348. And this is the Department of Natural and Cultural Resources requesting fee increases. Okay, good morning.
Good morning. Sarah Stewart, Commissioner of the Department of Natural and Cultural Resources. And with me is John DeVivo, who oversees Cannon Mountain at Franconia Notch State Park.
Okay, thank you. Are there questions? Senator Rosenwald.
Thank you, Madam Chair. Good morning. It's still morning. It's like an eye test reading this chart, but I did notice that most of the fees are staying the same. However, you've raised fees in 3 groups versus the previous winter. One is seniors, where the fees go up by about 1/3 from last year to this year. And then we have New Hampshire residents going up 10% and state employees going up 10%. So given this as a state resource, I'm wondering how you've decided to put the fee increases on New Hampshire residents or state employees that are hard enough to retain and seniors. Thank you.
Thank you for the question. For the record, my name is John DeVivo, General Manager at Franconia Notch State Park and Cannon Mountain Ski Area. So in every year we do market studies. We try to test and see where the ceilings are and what the market will bear, in addition to taking a look at what we've been charging for several years in any specific category. And in those specific areas, we actually felt like we had room to do minimal increases. The percentages may appear to be higher, but the dollar figures are not that high.
Thank you. So you're balancing what the market will bear versus how we could deploy this state resource to benefit the people of the state?
Yeah, whenever possible, we try to defer to our state status and protect those specific price areas for New Hampshire residents. For example, we're happy to do our New Hampshire Resident Wednesday. We've brought that back. We're happy to do all of our New Hampshire resident discounting, which we enjoy doing, but it's also part of an RSA. In specific areas, we will look and see where there is room so that we can remain viable and make some moderate increases.
Thank you.
Senator Daniels.
Thank you. In this last budget, we added significantly more to tourism to try to get people to come to New Hampshire. I feel that by raising the fees on them, it sounds like we're now fighting against tourism. You know, get up here, but we'll charge you more. So convince me differently.
Well, sir, we do have specific costs that we need to cover. We do have a requirement that we are essentially at market value. We do our very best to be more of a value than our 5 major competitors, and really any competitors. And we feel like we are the very best at hitting value for price paid in all those categories. But like with all other aspects of life, our costs have increased, and we do have a fiduciary responsibility to remain viable as a state agency.
Are there further questions? I do have a couple. And this deals with the $10 for parking. I know we implemented a bus program, and the object was to get people to take the bus. And if I remember, the parking fee was $5. Is that correct? Or, well,
Actually, I'm sorry. Actually, the fee-based shuttle system is for ridership rather than parking.
Oh, right.
And so most people at this point are dropping off at those trailheads and sending the driver north in order to spend less money, frankly.
Okay, so the buses, you pay to ride the bus.
Yes.
Okay. And how many parking spaces do you have?
Within the notch, we're approaching 2,000 in total. The item that we've put before you would be the ability to charge for 202 spaces right at the 2 very primary trailheads. One is the epicenter for Franconia Ridge. The other is the epicenter for Kinsman Ridge over on the Cannon side. All other parking spaces are free within the notch, and it's really dependent upon which venue or which trailhead you would want to go and hike. But that influx of potentially $80,000 would go a long way toward having a direct impact upon our ability to continue to run the hiker shuttle, which costs approximately $90,000 between fuel, rentals of the vehicles themselves, and wages.
And if I could add, the shuttle system was implemented as a pilot program a couple years ago. We worked really closely with DOT, safety, local authorities to try to solve the problem of 700 vehicles on a beautiful Saturday parked along the highway with dogs getting out and kids running around. That was really scary for all of us. So we agreed as the park operations to put together this shuttle system, and it worked really well. It's worked really well, and DOT continues to support this with their signage and their barriers along the way. So we just want to make sure it's a sustainable operation, and we're looking for ways to cover the expenses. And we feel like these 200 plus parking spots are really the primo spots that people would be willing to pay $10 for. And in contrast, or to show that this isn't a novel idea in our park system, if you want to hike at Mount Monadnock, you pay $15 to park at Mount Monadnock. So it's a similar situation there. You cannot hike Mount Monadnock without paying $15 to park. So it's an accepted fee.
Are there any other questions? Seeing none, could I have a motion on FIS 22-348? Senator Bradley moves to table, seconded by Representative Leishman. No, you had your chance.
No?
Okay, will the clerk call the roll?
Okay, the motion to table for 348, Representative Edwards.
Yes.
Representative Emmerich votes no. Representative Erf.
No.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley. Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susi. Representative Umberger.
Yes.
Madam Chair, the vote is 8-2 to table.
The vote being 8-2, FIS 22-348 is laid on the table. Thank you very much. We will now turn to tab 12 and FIS 22-366 for the Department of Health and Human Services, requesting that we review an approval of a plan for implementation of a pilot program for individuals with developmental disabilities between the ages of 18 and 21. So, would you please introduce yourselves?
Oh, sure. Chris Santinello, Associate Commissioner.
Melissa St. Cyr, the Chief Legal Officer.
Nathan White, CFO.
Thank you very much. Representative Edwards, you have...
Yes, ma'am. I think I have two questions.
Okay.
One, if we approve this, will the department consider this the fiscal committee approval of your plan? Is this meant to be a plan, or is this meant to be something other than the plan that we're supposed to approve before you go forward?
Sure. So HB 1661 from this past legislative session, it required that the department come forward once the all necessary coordination for the program had been sufficiently completed. And we need to request from the fiscal committee that we may begin implementation of the pilot program. There's also a secondary requirement that on or before February 1, 2023, the department will provide a detailed report of the pilot program plan. That is to come in the future, but this specific action is to comply with the aforementioned provision from 1661 that I had mentioned.
Thank you. To what extent have you already, or will you be coordinating this item after, as presumably it's approved, with the area agencies? Have the area agencies already been in this loop or not?
Yes, the area agencies have been in this loop. They were part of the whole process during the legislative process. And then we will be meeting with a group of area agency designated people to really walk through every time, we work on a child being found eligible and all of those instances. So yes, there's a lot of engagement.
So would you be surprised if I had heard from an area agency saying that they had not been included, and what they were hoping you'd say in answer to that question was not yet, but they will be?
Not always surprised, because when we work with agencies, lots of times we take representatives that represent multiple agencies or the entire system. But anytime these children, young adults would be coming through the area agency system, so they would be involved prior to having funding.
Are there further questions? I have a couple. First of all, I don't believe this is a plan. Okay? I mean, you list 3 items of what you, what the priority order is. When will you bring back a plan? I mean, an actual plan that says, here's what we are planning to do under emergency room, ABCD, or whatever it is. I mean, I don't consider this to be a plan. I consider this to be a high level of here's what we're looking to accomplish, but I don't see anything beyond that.
So this really is looking at filling a gap that exists, and based on the legislation, it is really targeting those children, young adults who have not exited the school system and are in need of residential services. And so those are prioritized here. And then throughout, what happens is then you go through the individual planning process that you do with any individual and family to determine what is the next step to serve them. The detailed report that we are to provide in February, which is just a few months away, will really get into the details as to who accessed the services, what types of services they needed, so we can really work on planning for the future if that's warranted.
So you're telling me February is when I'll get a more detailed plan?
You'll get a report in February. This is the plan just to get us started to accept the funds so that we can begin to assist those individuals who fall in this gap that exists in our state to figure out how to best serve them.
Senator Daniels.
Thank you. I want to share the chair's concerns, particularly in the area of funding. You're talking about this going to cost $140,000 per person, but I would expect the plan to break down where that $140,000 is expected to go. So, I saw this. I was actually kind of looking through to find out where's the plan. This seemed more like an outline to me.
So I just want to call to attention, the purpose of this item is to comply with the aforementioned provision of HB 1661.
Excuse me, Nathan. Yes. Bring your mic closer.
Oh, thank you. There we go. What I wanted just to clarify is the purpose of this item, the section that we're citing, is it reads that if the department determines that all necessary coordination for the pilot program has been sufficiently completed, we may make a request to the Fiscal Committee of the General Court to begin implementation of the program on an appropriate effective date. And Chris had cited the February 1 date, and that's the date at which we would bring that report. So this isn't necessarily the comprehensive plan. What you'll see in February is a lot more detail of that. This is more a compliance request to comply with that specific provision of the state law that was put into place. And this is the request for authorization to move forward with the program.
So I guess my question would be, why would we authorize you to spend money to start a program that we may not agree with in February?
The legislature approved this pilot as part of the last legislative session. So according to state law, we are required to do this pilot, and this is one of the steps that we have to take. And I'm going to ask Senator Bradley to please weigh in.
Okay. I would also state that the bill that you just read from also had the thing coming to the Fiscal Committee, which we look at the monetary aspects of it too. And right now, I just see a clump of money and I have no idea where it's going.
It's going to go to serve those young adults that need the services, and then the report that we do in February will give detailed information as outlined in the legislation as to the types of services, the number of young adults served, utilization.
Yes, well, I'm just, Senator Bradley, please.
Thank you very much, Madam Chair. So, a little history. The department brought forward a bill that I sponsored for the department 2 years ago that was wide open, that anybody 18 to 21 that potentially needed services was going to be able to obtain services in this way. The area agencies objected to that because of some of the unknowns that I think have been discussed here today. And as I recall, we in the Senate stripped that piece out of that bill. I think it was Senate Bill 160 in 2021. When the department again came to me to file another omnibus type bill, that provision was in the bill again, and I worked with the department and the area agencies and came up with the number of up to 20 kids to try to answer some of the questions that have been raised by both the department and other members here of the Fiscal Committee today. It would be my recommendation that we go forward with it. These are individuals that are potentially in need of services. We will learn a lot more from it and be able to, I would hope, figure out what the demand could potentially be. Is it 20 kids or is it 1,000 kids? We don't know the answer to that. I don't think you know the answer to that either. Correct. But at the same time, there are families with disabled children that have left the school system that until they're 21, there's an obligation to serve. So it seemed, and both bodies passed it, although there was, as you remember, Madam Chair, we had to move this bill into the parking garage. We parked it right there in 1661, but it was never, this piece was never really discussed, as I recall, in any kind of controversial way in all of the Senate hearings and I think all of the House hearings on the underlying bill. That's my recollection of the process.
I will not argue at all that there's a problem in the 18 to 21 age group. Okay, I have no problem with that because I certainly recognize that is an area of underserved, I think is maybe the right term that I should use. But your pilot program as it stands says it's basically looking at your first two items are homeless, for basically for homeless people. And your third item is individuals already receiving the maximum amount of services through in-home support. So,
So,
unless the legislation said that you were to focus on the homeless, that, I question whether those should be number one and number two.
well, it's a young adult who meets the eligibility criteria under RSA 171A, so they're already found eligible for developmental services system. And they do not have a place to live. Oftentimes, these young adults show up in the emergency room and they can't go home. And so when we say homeless, that is the term. It is not individuals who would be homeless under the homeless services system. These are individuals through the area agency system who are eligible under RSA 171A. That threshold has to be met first and have no home to go to, and are in need of residential services.
Okay, are there any further questions?
No, but Madam Chair, if I may, to go back to the what HHS is asking, I think more specifically, even though it says to in the item itself, it's I should have taken a closer look at this. Requesting review and approval of its plan. The chapter law itself, and I'm going to read it verbatim, is that if the department determines that all necessary coordination for the pilot program has been sufficiently completed, the department may make a request to the Fiscal Committee of the General Court to begin implementation of the pilot program on the appropriation effective date. And basically what happened, and Senator Bradley had mentioned this, is the legislature did appropriate $2.8 million for these individuals for a pilot program. I think there's a cap of about 20 individuals. But before HHS can even spend $1, they need fiscal to say, yep, are you sure you've done all the coordination for the pilot program and you're ready to go? And then fiscal will say yes, and you can begin to spend it. The paragraph before, and it could be a little out of order in that chapter law, that's where the requirement that on February 1st, 2023, the department shall provide a detailed report of the pilot program plan. That's the first and only use of the word plan to the Senate Health and Human Services Committee, Senate Finance, House Children and Family Law, House HHS Committee, House Finance, as well as Fiscal, not for approval, but to provide that to them. And then what the chapter law does is specifically outline what the committee should expect to see relative to what Christine was mentioning, the data on utilization, number of individuals, et cetera. So I think maybe the wording of the request is causing some of the confusion. What the department needs before they can even begin to spend that is the approval of fiscal to begin the implementation of the pilot program. The plan to be coming at a later date, that is not something that needs approval of fiscal, if that helps to confuse or clarify the situation.
I think the comment that the explanation wasn't really very good is probably the most appropriate thing you said. Okay. Are there any further questions? Seeing none, could I have a motion to approve? 22-336, moved by Senator Bradley, seconded by Senator Gray. Will the clerk please call the roll?
Roll call on 336. Representative Edwards.
I have a conflict of interest and abstain on 336.
Representative Emmerich votes yes. Representative Erf.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
No.
Senator Bradley.
Yes.
Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susi.
Yes.
Representative Umberger.
Yes.
Madam Chair, the vote is 8-1.
Okay, the vote being 8 in favor, 1 opposed, and 1 abstained, the motion passes. Okay, thank you very much. So we will look forward to seeing a plan in February. All right, we now turn to late item 22-371, which is in tab 13. Department of Health and Human Services is asking for dollars to develop a Sununu Youth Services Center critical staffing incentive program.
Hello, Nathan White, CFO.
Good morning or good afternoon. Joe Ripsum, Director, DCYF.
You want to say something?
Sure. You want me to just describe the item? I'm sorry, I was expecting a question. So what we're seeking to do here with support, the letter actually comes from DAS, with support from DAS through their recently authorized retention and recruitment authority, is to be able to provide a retention and recruitment enhancement for staff who work overtime shifts at SYSC. We've gotten into a very, very difficult staffing situation in that building. We are now down to, we need about 45 full-time youth counselors to run that building appropriately. We're now down to 20 full-time youth counselors to run that building. We do have a handful of temporary staff, which were approved at a prior fiscal committee here. That contract is to be able to have up to 18 at a time. At this current time, I believe we have 9 of those filled. It's been very, very difficult to hire, recruit, and retain staff. In addition, there has already been an enhancement approved by JNC on their salaries. Despite that, it still has been incredibly difficult to hire, retain, and recruit staff. That's put us into a position where we're having to rely even more greatly on overtime than in the past, and staff are really struggling to keep up with that overtime. The department has since put out a request for any department staff who are qualified to be able to be trained in working as a YC there and to receive overtime compensation for working there. In order to have enough overtime hours filled, we believe it's necessary to have an additional enhancement for folks to entice them to come in and work the overtime shifts. So that's where this comes in. The idea to try to entice more people to come into being voluntarily working overtime shifts at SYSC, or to provide additional compensation for folks who might be newly hired, attracted by the opportunity to earn additional overtime while working in the facility. The plan sets forth that anybody who works more than 24 hours of overtime in a pay period would be eligible for a $300 bonus in their paycheck.
Okay, thank you. Are there any questions? Representative Edwards.
Thank you, Madam Chair. Thank you, Mr. Ripson. The fundamental problem that you're trying to cope with, as I understand it, is that we have on the books in the RSAs a closure date of 30 March, and there is no replacement plan in law at this point. And that's the 800-pound gorilla making it difficult to recruit and retain. Is that correct?
That is a huge contributing factor. I believe there are probably other contributing factors, right, such as, underlying salary, which we've tried to address, such as the general cloud over the facility, given the horrible things that have happened in the past there. But yes, we saw actually, once we were unable to have a resolution on that issue in the last legislative session, an additional third of our current working YCs had resigned because they had seen that, there was not necessarily a future for them. And it's incredibly difficult to operate a facility when you have that type of ambiguity over the future state.
Yes, please.
Okay, so it seems like it may be necessary but not sufficient to extend the closure dates so that at least the retention problem is minimized. I don't see how recruiting can really benefit until we have a replacement plan, until we know what the future looks like. I think we can keep people around, but recruiting them will be tough without a replacement plan. That's my theory. What do you think?
I believe that's true, but not necessarily the entirety of it. I do think that, if there is, public signaling and support that this is going to be resolved, that too will help, right? I think a lot of this is that folks really aren't quite sure what's going to happen. And, even if it takes time for the legislature to come up with that replacement plan and to extend out the dates into the next session, which I don't believe there's any alternative to that, right? I don't believe there's a possibility to do anything sooner than the beginning of the next session. The fact that even this conversation has started and there's been public reports about the extension of all of this has already helped us in these conversations with staff and trying to say, look, there is a future. People are working towards this. But it's incredibly important that progress continue to be made so that people continue to see that they do have a future.
Excuse me.
May I?
You may.
So I think I've heard you described a three-legged stool here. That the issues that's causing your recruiting and retention problems, you could summarize maybe in three legs. One, that we have a closure date on record, that you have salary issues just to bring people in, and that you have sort of a goodwill messaging component of it, that if people in the department are hearing that the legislature and the public is interested in working on that first problem, which is the closure date, that those three things in combination could help address your concerns.
Yes, I believe that's accurate.
Is there a fourth thing?
I think that's accurate. That's what's coming to mind.
I mean, I don't think there's anyone in the legislature that believes that the Sununu Center is going to close on 31 March. I don't know how you reassure people that they'll have jobs on 1 April, but it's not going to close. It can't. So I don't know if that helps or not, but we'll do our level best to get legislation through quickly in January that will hopefully help with with people understanding that there is a future, although it may not. 45 people is what you were talking. You would probably require 45 for any new building or whatever. So I know it's a problem, and but we'll get there. Okay.
I appreciate it. Thank you.
All right. Are there any further questions? Senator Susie.
Yeah, if I may, I certainly recognize closure date and messaging being significant issues, but I wonder if you could just update us. I believe with respect to the salary issue, collective bargaining negotiations play a huge part in this, and the role the state has played vis-a-vis the employees, I think has also exacerbated your problem. I wonder if you could speak to any specific issues that might be addressed soon in that bargaining agreement?
Yeah, so the immediate or short-term attempt to try to address that was through salary enhancements, which were approved by GNC a little bit less than a year ago. That pushed the SYSC frontline staff salaries to really be in the range of like $15 to $20 an hour, which if you go and look at what folks are paying at grocery stores and such, right, in the current environment, that's not incredibly competitive. And that was after the salary enhancements, right? So I think this is all happening in the context of a few other things, right, that I don't think we have direct control over in the immediate term, but that I do think in the long term should be, or in the intermediate term should be thought about, right? One, we do have an overall workforce issue in the state in general, and specifically in areas of direct care, right? So direct care in all different settings, but particularly in my wheelhouse and where I'm concerned is around people who provide direct care in residential settings. That's true for our private residential programs. It's true for SYSA, and it's not just a New Hampshire issue. Every state in the country is facing the same thing. I get clips sent to my email every morning from around the country for juvenile justice and child welfare related issues, and you'll see a story that sounds just like this all over the place. So I think there's a big issue there, and that the workforce, the compensation for that type of work hasn't really kept pace with the rest of the economy. So I do think there's an opportunity to think about what is an intermediate or long-term solution to that problem. What we're really proposing at this moment is just a Band-Aid to try to get us through the immediate term.
Thank you. Are there further questions? Seeing none, could I have a motion to accept? Representative Edwards moves FIS 22371. Seconded by Representative Erf. Will the clerk please call the roll?
Roll call for 371. Representative Edwards.
Yes to 371.
Emery votes yes. Representative Erf.
Yes.
Representative Leishman.
Yes.
Senator Daniels.
Yes.
Senator Bradley. Senator Gray.
Yes.
Senator Rosenwald.
Yes.
Senator Susie. Representative Umberger.
Yes.
Madam Chair, the vote is 10-0.
Vote being 10-0, FIS 22371 passes. So, Mr. Kane, I understand you have something for us.
Yes, thank you, Madam Chair. The administrative procedures of the committee, adopted at the beginning a couple years ago, requires that our office request authority to fill a position when we found a candidate and have a vacancy. We do have a vacancy which is funded. We have identified a candidate who has accepted our job offer pending approval from fiscal. So I would just ask the committee's approval to fill an auditor position.
Senator Susie moves, Senator Rosenwald seconds. Do I need a roll call?
Either show of hands, roll call, whatever you're comfortable with.
Show of hands on whatever, Mr. Kane hiring somebody. Oh,
Yes, yes.
what's really exciting is that you actually have someone to fill the position.
We do. We kind of cheated. She worked for us before a few years ago, so we had a little leg up on that finding.
It doesn't matter how it happened. It's good that it happened. Okay, we have several information items, and we have a briefing on PFAS in our landfills. So are there any questions on any of the other information items? Yes.
Lottery?
Okay, is someone here from lottery?
Hi, Jim Durst, CFO, New Hampshire Lottery Commission.
Thanks for taking my question. So I think I noted a decline of about 6.7 million in sales. Could you just tell us why we're seeing a decline?
Yes, there's really two factors in there. During the COVID period, our sales increased greatly with sharp increases that were unexpected at the time. So we're having the combination of that coming back a little more to reality, what I would call reality as the finance person, but coming back more into line, still over prior years. If you go back to 22 and 20, we're still above those numbers, just not going where 21 was. Secondarily, we also see the rising prices of food, gas prices, things like that, which obviously have, especially gas, have a direct effect of when you buy gas and go into that store, you don't have as much free money to spend on tickets.
All right. Thanks. Thanks, Madam Chair.
You know, it's interesting. I got the same answer from Charlie McIntyre. So they're talking to each other, which is good to know. So thank you very much.
You're welcome.
So DHA environmental folks, if you would. I think all of you received a copy of the briefing. So this kind of, there was something that came about that said this is a problem that we're going to be facing probably in the next budget, and I don't know where we're going to get all this money from. So if you would, Commissioner, please
Thank you, Madam Chair. For the record, my name is Mike Wimsat. I serve as Director of the Waste Management Division for New Hampshire DES. And with me today is Jamie O'Rourke, who is a hydrogeologist in our Hazardous Waste Remediation Bureau, and much of his work focuses on landfills and landfill monitoring. As the chair indicated, there was a question that came up at a prior meeting about PFAS, particularly as it relates to our landfills in the state, and as it relates specifically to its presence in leachate, which as you'll learn from Jamie, is a significant management issue for landfills that do collect it. With that, I know we've got running late here today. I'm going to turn it right over to Jamie. He's got a presentation that I believe has been shared with the committee members. Probably runs about 15 minutes or so in length, and we'll be happy to answer any questions either along the way or after Jamie's completed.
Good afternoon. We do have copies of the presentation if someone doesn't have one with them, if they'd like. I've got 25 more here if you really need them.
Yeah, thank you.
Please go ahead.
Thank you very much. Good afternoon, everyone. We were invited over to give a quick little discussion on PFAS occurrence and leachate at New Hampshire landfills, and on the interest of time, I'll be moving rather quickly on some of these slides that are more high level. Within the first several pages, these are numbered as well. If you'll note in the bottom right-hand corner, we have the first page here is a listing of the active lined municipal solid waste landfills here in New Hampshire, along with their locations. The next page is simply a listing of the various wastes that can be found or disposed of in New Hampshire landfills. Not all landfills can take all of these wastes, but a majority of them, and all of them for certain, will be taking municipal solid waste and wastewater treatment plant sludge, which we'll be discussing in a few minutes. As we move along here, landfill leachate management in New Hampshire, leachate is actually defined in the solid waste rules. It means a liquid, including any suspended components in the liquid which has contacted or passed through solid waste. As that liquid passes through a landfill's waste mass, it leaches or extracts chemicals or constitutes from the wastes as those wastes break down. Along with PFAS, this can include numerous different chemicals and compounds, as well as the PFAS, organic compounds, heavy metals, chlorides, nitrates, so on and so forth. The material ends up being quite a noxious fluid, very thick, viscous, almost like a brine or a thick soup, if you will, very challenging to manage and deal with. Following the discovery and of the extent of PFAS impacts to the southern part of New Hampshire, DES started becoming concerned about the potential for PFAS within the landfills, and specifically the landfill leachate. In 2018, DES conducted an initial sampling survey of leachate from 9 landfills in New Hampshire. That includes the 6 active landfills as well as 3 closed landfills that also generate leachate. The results were rather interesting and very wide-ranging. A wide variety of PFAS were detected at varying concentrations across the board. All 9 landfills had PFAS. There wasn't necessarily a theme or a rhyme or reason as to the scale or size or even age of the landfill, whether it be closed or still active. The next study that kind of came to our attention was actually our neighboring state of Vermont in 2019. They required their only operating landfill to conduct a study of potential PFAS sources in waste stream. So essentially what they did is they had their landfills sample the waste as it was coming into the facility, trying to determine where are we seeing this PFAS in our leachate coming from. Well, the answer was it's pretty much across the board. There's a snippet of a slide at the bottom of the page that I've included, and you can see there's PFAS detections across the board from sludge to bulky items, textiles, carpeting, mattresses, couches, so on and so forth. So there is, as we all know now, which we didn't necessarily know as much in 2019, is PFAS is rather prevalent across our society. So in New Hampshire, the current management of leachate is rather universal. Leachate is captured in the landfill's liner system below the waste that's there, and it's either shipped or piped to a wastewater treatment plant. It's about 50-50 versus trucked versus shipped with our active landfills. At the wastewater treatment plant and within the process itself, there is a negligible destruction of PFAS. In fact, it partitions off to the water effluent as well as the biosolid sludge material. As a result, there's relative impacts on the back end. The receiving water quality will show impacts from PFAS, and the sludge itself shows impacts as well, potentially limiting its management options. Instead of being able to possibly be used in land spreading or in composting, one of the other options is that it goes to landfills. In fact, a majority of it does. There is one active landfill in New Hampshire that actually pre-treats its leachate, which we'll be talking about in a little bit. It wasn't necessarily designed to be pre-treating for PFAS. This is the Turnkey landfill in Rochester. They've actually been pre-treating their leachate since the 1990s, so well before our knowledge of PFAS came around. I'll talk about it in a little bit more detail. They've been doing some interesting work that we've been discussing with them. But as I outlined above, there's essentially this cyclical relationship between landfills and wastewater treatment plants. A landfill generates leachate, it gets shipped to a wastewater treatment plant. The wastewater treatment plant generates a biosolid, and in most cases, it gets shipped to a landfill. There are obviously a couple of offshoots off of that relationship with the water effluent, which may come off and impact streams and rivers. And then also that biosolids component, in some cases, there are some beneficial uses that are there in which they have been used for. On the next page, we have a table of the various volumes of leachate that have been generated at the 6 municipal solid waste landfills across New Hampshire. These are the last 3 years of numbers that we have. As you can see, the numbers vary greatly from location to location, but also from within facility from year to year as well. Now, the numbers obviously will relate to the landfill size and scale of operations, but there are some operational steps that a landfill can take to limit the amount of water that infiltrates into the waste mass. If you use a tighter cover on a daily basis, you can shed some of that water instead of generating as much. So there are some potential steps you can take to limit landfill leachate generation. At the bottom of the page, there are 6 closed landfills that also generate leachate. They generate leachate at a much, much smaller rate, given that they are closed. They are capped with an impervious material to prevent liquid and water and rainwater to be from migrating through the waste mass and generating more leachate. Essentially, with the liner underneath and the cap on the top, we've created somewhat of a closed system. So the leachate is coming out, and those numbers drop off precipitously after closure, almost exponentially within 3 years. We wanted to take the time today to discuss, at least very briefly, the occurrence of PFAS in groundwater at New Hampshire landfills. We obviously have these occurrences in leachate, and we have been aware of and sampling around landfills consistently. DES required groundwater sampling for PFAS at all lined and unlined landfills that have groundwater release detection or groundwater management permits. So groundwater monitoring permits that run in perpetuity, essentially, for the landfill's existence and beyond. As of March of 2022, 90% of the landfills have been sampled for PFAS. This includes all the lined landfills and all the active landfills as well. 91% of those have had PFAS detections. 77% have had PFAS detected over ambient groundwater quality standards, or AGQS standards, for one or more of the 4 PFAS that we regulate. A not insignificant number is 22.5% on that last line. We've had that number of landfills that have either had PFAS detected below standard or not detected at all in groundwater sampling around them. At the bottom of the page, there's a table where those numbers and percentages were derived from. Just a little reference point for you. When you look at the lined landfills, some of the lined landfills in New Hampshire have unlined landfills associated with them, either butting up against them or right next door. So when we calculate those numbers, when we look at that monitoring data, those might be representative more of the unlined landfill as opposed to some kind of operational challenge with the line system. The next page is essentially the same numbers presented in a slightly different way, just a simple pie chart for us. You can see that 3/4 of the landfills have detections over AGQS, and the other 22% how they're divided. We have had 174 landfills in New Hampshire screened for PFAS at this time. We're hoping and anticipating being able to get the rest on board as well. One note here, the data from this groundwater information was submitted previously in our status report on the occurrence of PFAS contamination in New Hampshire dated June of 2022, a much bigger report that I believe was submitted directly to this committee. Obviously, with groundwater impacts at landfills, DES is always concerned about drinking water because groundwater is such an essential source of drinking water in New Hampshire. As a result, there has been extensive drinking water sampling around landfills conducted by the responsible parties, municipalities, and such. PFAS has been detected in drinking water supply wells exceeding AGQS at 6 closed landfill sites, totaling 24 water supplies that have been impacted. Each of those impacted water supplies has been provided a permanent potable water solution, so either some kind of treatment system on their water supply well or a connection to a water utility, or they're being provided bottled water until such a permanent solution can be provided by the responsible party. In approximately half of these cases, contaminants other than PFAS were previously detected at the water supply wells above their respected AGQS. So about 12 of these were already being monitored for other impacts from a landfill. And as a result of PFAS coming onto our radar screen, we decided that they needed to sample for PFAS as well, and it was found as part of the process. Those residents were probably already on treatment systems already. At the bottom to note, to date, there have been no detections of PFAS over AGQS in water supply wells that have been sampled near active landfills. So we framed the issue a little bit, and what are some potential steps we can take in the future to deal with this, deal with leachate? We could continue on with the current practice where wastewater treatment plants are required to just meet their applicable standards. So if there were and will be surface water standards for PFAS enacted, the wastewater treatment plant would end up needing to be able to comply with those. That would also relate to possibly the sludge disposal, where there be limitations on their ability to be used in some fashion for beneficial use. One of the things we could do, if we wanted to consider a requirement to pre-treat the leachate before it's placed into the wastewater treatment plant's process. You could have on-site pre-treatment infrastructure at the landfills. You could develop a pre-treatment infrastructure at the wastewater treatment plant so that it's not getting into the system. One of the other ideas that has been thrown around a little bit and has received some positive feedback is the idea of a regional pretreatment facility where these landfills bring their leachate so that it can be treated appropriately by a state-of-the-art type facility and then have it disposed of at a wastewater treatment plant. You could co-locate this with a wastewater treatment plant, possibly. One of the other things we need to consider as we go through this process and evaluation is what's the significance of the benefit by removing the PFAS that leachate brings into a wastewater treatment plant? How much PFAS are we removing from the total that may be coming out of the pipe? As we talked about the potential waste that go into landfills, we know that PFAS is prevalent throughout our society. It was raining this morning. If we had Gore-Tex or some kind of other waterproofing on, we might have had PFAS and part of our clothing, cosmetics, so on and so forth. So there will be significant PFAS in wastewater treatment plant already. How much help are we giving by removing this PFAS from the leachate? There is significant sampling that's been being done by DES and the Water Division to be able to make some informed decisions on this as we move forward. So there are treatment technologies that would be available for us to be able to treat leachate. The first three may look rather familiar to you. They've been used extensively across New Hampshire to treat drinking water supplies that have been impacted by PFAS with granulated activated carbon, ion exchange resin, and reverse osmosis. As I indicated earlier, one of the challenges that at this stage with dealing with leachate is its viscosity, is its components, is its suspended solids. If you were to apply PFAS to one of these technologies directly, you would end up fouling the system almost instantaneous on a daily basis. So what you end up needing to do is have what's called a treatment train or sequence of treatments that can get the leachate to the point of being able to use this technology. It's not impossible. In fact, it is done. It just adds a great deal of complexity and maintenance related to these locations. There are new and emerging contaminants, or new and emerging technologies for these emerging contaminants. Foam fractionation, which is the generation of a PFAS foam off the top of the leachate that can be skimmed off and disposed of. Stabilization or encapsulation, which is the creation essentially of a solid or a concrete that can then be disposed of back into the landfill. One of the ones we're most interested in is supercritical water oxidation. It is a relatively new technology that's being tested out there, but it actually applies heat and pressure to be able to destroy the PFAS compound. Obviously very ideal, very much on the front end. There are some pilot studies out there that we are aware of. In fact, the Wastewater Engineering Bureau has received a infrastructure grant to be able to run a pilot study on treatment of leachate from a wastewater treatment or from a landfill prior to its being delivered to a wastewater treatment plant. They're hoping to get numbers out of that within in 2023, in the summer of 2023. The Turnkey landfill of Rochester landfill, excuse me, they've also been running their own pilot studies as a commercial entity. They've been doing this. And we became aware of some rather interesting information that they provided to us, in that they've had successful runs of running a pilot study on a full-scale basis. They're hoping to be able to take the next steps into the future. So we hope to be able to learn a lot from them as they move on with actual operational tendencies when it comes to the treatment of leachate. In summary, there are 6 active municipal solid waste landfills in New Hampshire that are generating approximately 96 million gallons of leachate per year. Leachate quantities generated very widely by landfill, generally based on landfill size, but not exclusively. There are some operational steps you can take to limit that generation. Operational timeframes and landfill sizes do not always correlate with the concentrations of PFAS and leachate. PFAS is found in a wide-ranging number of waste types. There is this cyclical relationship we discussed between landfills and wastewater treatment plants, where the landfill generates leachate, gets sent to a wastewater treatment plant. The wastewater treatment plant generates a biosolid. It gets sent back to the landfill itself. There are potential leachate treatment options, as we discussed. They haven't been fully vetted necessarily at an operational level at New Hampshire landfills. And as I discussed on the last slide, there are some pilot studies that we're going to get some information from over the next year or so. On the last page, I've included my contact information as well as Director Wimsatt's. We are available for questions if there's time now, or if you have questions at another time, you can feel free to reach out to us, please.
Oh, go ahead, Senator Gray. Sorry.
Since I'm also a city councilman in Rochester, the history of why they pre-treat in Rochester has to do with nitrogen and nitrate. Because of the discharges into Cocheco River, which is impaired for, and so it didn't have anything to do with PF compounds. Just want to make sure that that's clear. And waste management, I didn't even know that they were running a pilot on PFAS.
Yeah, I had a conversation with them just very recently where I mentioned that we were going to have this discussion, and I wanted a bit of an update as to what they were doing. And they dropped this on us in a favorable way. There's no requirement from us for them to be pre-treating their leachate. As you discussed, it's a local matter. And the PFAS component, I think, is a matter of disposal. From an economic standpoint, at one point, they were shipping their leachate all the way down to, I think, New Jersey at some point. That's not sustainable for them. So they, I think, invested in monies into trying to take the next steps into keeping it local, if you will.
It's rather scary when your landfill says to your wastewater treatment plant, you cannot bring your leachate to me anymore. Because then you're kind of looking around going, I don't want it in my backyard, but it's the kind of thing that I'm really, really concerned that this is going to blow up in our faces. And that I think is a real problem. I mean, everybody that has a, doesn't have a, has to have their tanks pumped. All that goes to some wastewater treatment plant. And it's my understanding that the concentration of PFAS in your thing that you have at home is higher than what comes into the wastewater treatment plant through the sewer system. So it's, I don't know.
Well, thank you, Madam Chair. If I may, you raised a really good point. So as with many topics, it's sometimes very location and facility specific. A landfill that sends its leachate to a fairly large scale wastewater treatment plant that has many millions of gallons a day of flow that it's treating, that daily shipment may not represent a significant portion of the influent to that plant. And in fact, as Jamie indicated, it may not represent a significant proportion of the PFAS that comes to that plant in any given day, and therefore doesn't necessarily influence the final concentration in the receiving stream. Most of those large volume wastewater plants discharge to a relatively large river, receiving body. On the other hand, there may be other small wastewater plants, as we have a few of them in New Hampshire, that don't have the luxury of discharging to a receiving stream or a river. They may do a direct groundwater discharge through rapid infiltration basins or some other such technology. And in those cases, the impact of that effluent discharge, it has an immediate impact on groundwater quality. And so for those types of facilities, it's a much more difficult question. So as with most things, the best solution or even the need for a solution may be dependent on the particular wastes involved, the particular facility, and the circumstances they're operating under. So we're looking at all those. We have very close working relationships with all of our wastewater plants. And when they run into problems like that, we're working to help them. And actually the pilot study that Jamie mentioned is actually focused on one of those plants that has a rapid infiltration basin to try to help them kind of get their arms around the problem.
Are there any further? Yes, Representative Leishman.
Thank you, Madam Chair.
Oh, is your name Representative Leishman?
Oh, I'm sorry. It could be.
He would like it to be.
Oh.
I pass his cards out at the bar.
Go ahead, Representative Edwards.
Oh, I'm so sorry. Okay, so on page 15, you have several treatments in healthcare. Prior to worrying about treatments, we build in a whole preventive medicine prevention program, and I'm just curious if there's also a prevention aspect of this that you guys are including in your thinking, but is not in this report.
Yeah, thank you, Representative. That's a great question. And yes, the answer to that is yes on both a state scale and a national scale. So on the state scale, as I said, we have close working relationships between our water division and these wastewater plants. When they start, and we've been doing at the state level to assist them a lot of testing to understand what they're getting in for influent concentrations of PFAS, as well as what they're discharging out, for treated effluent. And when they find a problem that seems anomalous, when they see concentrations that are particularly high, some plants have even gone to the trouble of going, and it helps you understand things better, going to different locations in their collection system to try to find out if we are getting increased PFAS, where is it coming from, and can they tie it to a particular commercial or industrial facility that may be using PFAS-containing materials in their manufacturing processes, and they're ending up discharging them in their wastewater. So there's a lot of work that's been done to identify that, and then that's when you get to the prevention piece. If there's a problem, if that facility can use another material that doesn't use PFAS to get it out, that's a great solution. If they have to use it for their particular manufacturing, then they can look at removing that PFAS prior to just it getting into their wastewater and discharging to the wastewater system. So that's sort of the state level and local level prevention that we work on. Also, there's a lot of discussion nationally that at the end of the day, if we're going to solve this PFAS problem, we kind of have to we absolutely have to significantly reduce the presence of PFAS in commerce. That means that there's probably a lot of uses for these materials, while helpful and convenient, may not be entirely necessary. And when you run a cost-benefit analysis of the benefit that product gives you by using PFAS versus the cost associated with managing wastes or the waste itself when you throw away that product. There's a lot of work going on there trying to really reduce the amount of PFAS that's used, and industry is already making steps there. They have lots of reasons not to be famous for having PFAS in their products. So there's a lot of work going on to try to reduce or eliminate the use of PFAS in certain manufacturing.
Thank you. So as I'm looking at the alternatives, I assume that one of the big factors is not only just the efficiency, the effectiveness of these techniques, but also the energy consumption.
Yes.
I would assume that some of these are energy hogs more than others. And so that's all part of your analysis, I presume.
That is correct. There is, as with most things, there's never a perfect sort of silver bullet. Everything has pros and cons. And again, the answer for one facility may be very different than another. You know, if you're treating drinking water and you're a small facility or even a large facility, granulated activated carbon turns out to be a very time-tested, effective, and though expensive, still a cost-effective means of treating drinking water. As Jamie mentioned, when you start talking about treating leachate, it gets more difficult. You got to do a lot more pre-treatment. And in fact, Senator Gray mentioned the turnkey landfill in Rochester. The work that they did to remove nitrate that goes back to the 90s, the treatment train they developed there for many years has had a series of steps which ends with a reverse osmosis step, which you couldn't do on untreated leachate, but once they've pre-treated it sufficiently, they can do that. They had no way of necessarily knowing it, but even when we weren't paying attention, we didn't know much about PFAS. Their treatment through the reverse osmosis process was removing PFAS. So the effluent that they were sending, or the pre-treated leachate that they were sending to the Rochester City wastewater plant, had largely had the PFAS removed for many years.
Representative Leachman.
Thanks, Madam Chair. Mike, I'm sure the chairman is correct as far as this is becoming an explosive situation, but is the department looking at additional sources of funding to help correct, or do you plan to ask for additional funding in the next budget to address this issue?
Well, as you can imagine, we have a lot of things going on with PFAS, and over time, funding has been provided to the agency through some general fund appropriations to help, particularly drinking water plants, put on treatment. There's been a significant amount of federal money that's been made available for that. We also have access to the Drinking Water and Groundwater Trust Fund, which is provided in a number of cases some funding for a variety of both research and treatment processes or projects. We've done some research. We need to really understand where we have PFAS in soils, where we have PFAS, where does it occur in groundwater and drinking water in the states. So we've used some funding to do those studies. And we've also, our primary focus is to make sure that people aren't drinking contaminated water. So much of the work we've done and the monies that we've spent have been on a combination of testing to understand where we have it occurring in drinking water, and then making sure we get funding to both community and municipal water systems to get treatment on so that they can serve clean, safe water. So the short answer to that is yes, we continue to seek funding and work with this specific issue. You know, I think as you may have surmised from Jamie's presentation, in some respects, this issue is that the market is sort of driving a lot of it. We're doing a lot of the work that we've described here to work with our wastewater plants, understand where the problem is and how to solve it. But in fact, the landfills and the wastewater plants together have a lot of incentive to try to get this out of their systems. So as was presented by Jamie, you know, the turnkey landfill, which is the biggest operating landfill in the state, has already been doing work to really develop pretty advanced procedures for pre-treating leachate. And the wastewater plants help to drive that, because if at some point a wastewater plant decides we don't want to take your leachate anymore because we don't think we want to have to worry about it in our treated effluent, that comes back to the landfill to find a solution. So one of the things that I think we may look to do is have further discussions with the landfills and with the wastewater community to understand whether and Jamie touched on this, whether a regional pretreatment facility would be an effective and a cost-effective means of improving the quality of leachate that eventually gets delivered to these wastewater plants for treatment and disposal. So there's a lot going on there, and we still have yet a lot of work to do and a lot to learn.
Thank you. Thanks, Madam Chair.
Yeah, Senator Bradley reminded us that they were just given $25 million in PFAS remediation money, but whether or not any of that will go to the wastewater side, I don't know. But it's an issue that needs a lot of thought, and I truly appreciate it, Mr. Winstead, for your presentation and your concern.
It's our pleasure. Thank you. And if there are follow-up questions, both Jamie and I are happy to field them. Just feel free to reach out to us using the contact information in the slideshow.
Okay, thank you. If no one cares, adjourned.
It'd be really cool if we could take that PFAS effluent and turn it into an energy source. Yeah.
No.
Maybe we could ship it to Ukraine.